Hello and good afternoon. Welcome everyone. Uh, Nathan up in the control tower here has just signaled me that I'm running a little late here. I need to get up and introduce the program and get on. I'm seeing stragglers come in, but this may be our full house. Welcome. Thanks for coming. We're always so delighted to have people because you come with questions also, and well, hopefully we can answer, or at least together we can try to answer questions you have. Um, Most of you have been here before and you realize the presenters are resident physicians in their uh, first 3 years of internal medicine training after receiving their medical degree. Um, so typically we have a first year resident out here, as Dr. Skaggs is, and an upperclassman, as Dr. Malhotra is, third year. So I'll introduce them as presenting the program, and we'll have questions and answers at the end. I think I'll introduce Dr. Skaggs first. She's going to be the second one to talk, but Dr. Skaggs is a native Archie. Just down the road, West Fork. How many people have been to West Fork? Hey, yes. Beautiful, beautiful town in the hills. And went to the University of the Ozarks. Now, I don't see Dr. Helen here. She also is an alum of Ozarks, University of Ozarks. So I'll have to remind her of that when I see her. She is one of our UAMS graduates who did their first, as they started being able to do a few years ago, doing their first 2 years at the main campus of UAMS in Little Rock, doing their third and fourth year, their clinical years up here. So she's one of those, and we're awfully proud of Chesney Skaggs from West Fork, Arkansas. So Dr. Malhotra, Dr. Vivek Malhotra, is from a little bit farther away than West Fork. You might think Malhotra, maybe he's from the Indian subcontinent. Many of your family, I'm sure, is, but he was born and raised in South Carolina, and I've tried to pump out of him just how he got here. Well, there is a cousin on faculty at UAMS, one of my colleagues from years in geriatrics, Dr. Mendarata, is his cousin, not aunt, cousin, even though she's older than you. Yeah. So he graduated from the University of South Carolina and came straight here. We were lucky to get him. So with that, people were running to get here for this program, I know. Or maybe it's a little sparse today because it can be a little bit of an embarrassing topic. We'll try to take the embarrassment out of it and just give you the facts. Okay, Dr. Malhotra.
Right. I'm rather loud, so hopefully everyone can hear me, but urinary incontinence, I pee too freely. It's an embarrassing topic to some, but I feel like it should not be. We should hopefully can try and take some of the stigma out of this fact that I can't hold in my urine. And most of all, it's something that many, many people do not seek treatment for. They don't bring it up to us. And quite often, as we walk through these slides, you'll see that we rely on you to tell us some of your symptoms, and that's how we can shape treatment, move through the treatment cascade. So what does incontinence mean? I don't think I have to define it for a lot of the geriatric population, but it's an involuntary loss of urine. Whether that means incontinence or not is basically, does it spill out of your bladder? Like I said, a common but underreported symptom in women especially, after the age of about like 30 or so, number can reach as high as 50% of women may experience some kind of incontinence. And we have several different types that I'll kind of go through here, but it's something which really affects your quality of life. Who wants to be chained to the bathroom and think, I'm not able to go out and live my life as I want to? So none of these things, and it's unfortunately also a complex topic. You know, something complex and somewhat embarrassing to people might mean that we may have a lot of time when it takes to address your symptoms. So hopefully you can kind of see how we think about incontinence and the various steps that we try and take. All right, here are various definitions of incontinence. Urge incontinence is the most predominant among our geriatric population for many different reasons, mostly including your just inability to stop yourself from feeling like you're going, and a kind of a loss of tension in the structures which hold in your urine. The other two are stress incontinence, meaning every time I cough or exert myself, I have some loss of urine, and overflow incontinence, the feeling that I have too much in my bladder, and some of it sometimes kind of comes out. So, and there's mixed incontinence, which has features of both, and so you kind of have to try and treat both. Here's a nice little kind of diagram, little cartoon on what we're thinking. Oh, this person's gotten up, and they have the urge and rush to go to the bathroom. It's typically not preceded, it's preceded by a physical urge, a need to go and urinate. So. All right, and I say a couple things up here. For women and men, we're kind of thinking of different reasons as to why. The most common are, so I say urethral hypermobility over there. All that means is that a weakened pelvic floor. Often this happens because of vaginal birth and just a weakness of those floor muscles as we age. Another thing up there, which is a little harder to treat, is a kind of loss of tone in the urethral sphincter, which is going to lead to more need to kind of urinate. For men, often this is after urological surgery, especially prostatectomy and transurethral resection of your prostate. And there are some therapies we'll kind of go over that should happen in the short period of time after to kind of help ameliorate those symptoms. All right, stress incontinence. As you can see again, our character has made another appearance. So you don't really have an urge to kind of go until suddenly you stand up, you cough, you sneeze, you lift weights, and then you have loss of urine. This often, I will just say, hey, I trust that your symptoms are coming here, but if we're not entirely sure whether stress incontinence is one of the reasons why you're having incontinence, a bladder stress test is one of the ways that can be done in the office to judge that fact. What this pretty much requires is either standing, sometimes in maybe a reclined position, or what we call the legs up dorsal lithotomy position. You inspect the urethral opening and make sure that when somebody bears down or exerts themselves, is there loss of urine. This is a good way to basically rule out that it's happening, but if you can't see it happening, it's a visual kind of index. Most people will just say, yeah, I have urine that leaks into my underwear. It happens. So that's really the only testing that we do. A urine analysis, we always ask that for everybody. Do you have a reversible quick reason as to why you're losing urine? So, okay. And our third type is overflow incontinence. Overflow incontinence, as you can see, this person maybe has just voided themselves, but there is an incomplete voiding. There's a extremely full bladder, but maybe there's a little bit that has trickled out as a result. So it's not as clear from this diagram, but one way you could kind of almost say it is that it's like a balloon that is filled too much, and you have little bits that is kind of leaking out as we go. And then you try and empty the balloon, and you aren't able to fully kind of evacuate the balloon, and whatever's left over kind of causes some of the incontinence that may be experienced. So, what's next? All right, kind of causes. For women, this is a lot rarer. For men, it's very common, but with the prostate kind of anatomically closing off the urethra, causing this distension. For women, it's more like neurological disease, MS, peripheral neuropathy, medications that kind of cause you to retain your urine, or outlet obstruction, but often that can be due to unaltered strange anatomy, or even kind of things that obstruct the urethra, like malignancies, cancers. So. All right, This is unfortunately didn't come up as well as I'd hoped for, but it's so common in men that this is the American Urological Association scoring chart for severity of your symptoms. I believe it goes up to like 20 something. So, but you can say how severe are your symptoms, nocturia, how weak is your stream, things like that. So these are but one of the aids that we can use to quantify how bad is the overflow incontinence. So you can see as I'm going through this talk, the most important thing that kind of comes from it is the sharing of the symptoms, how we can develop that and kind of figure it out through therapeutic alliance with you guys. So it's a sensitive topic, but our best information comes from you. It's a clinical diagnosis. So, and okay, this is just another kind of survey that we like to use. It's called the 3 IQ survey. One way of basically breaking down when do your symptoms start? Do you have nocturnal kind of spilling of your urine? Does it only occur with effort, like I mentioned earlier? Or is there are you drinking too much water? Things like that. This is another kind of diagnostic aid we can use to break down which of your symptoms kind of fit into which of the 3 categories. And like I said, there can be a lot of overlap. So, all right. Medications. I wanted to talk about medications because there are tons and tons of medications that can kind of affect how your bladder function. And I only highlighted a couple that are up there. The ones that I kind of wanted to talk about mostly are your sedatives, your opioids, and anticholinergics and diuretics. In general, when I'm talking about anticholinergics, I'm talking about Benadryl, medications like that. Amitriptyline kind of fits in that same category. These medications can cause one to have decreased sensation, decreased ability to empty the bladder. So when I was talking about distension of the bladder earlier with overflow incontinence, this is one of the medications that can cause it. Often when we are seeing you guys in the clinic, a good medication review can kind of tell us, oh, you have a high anticholinergic burden of medications that cause side effects. So the long-term effect of those include urinary retention, kind of fecal retention, confusion, inability to avoid your bladder properly, and long-term can have maybe less mental clarity as well. So that's probably number one when I'm looking at medications here. Sedatives, in particular, I'm talking about sleep aids. Similar kind of side effect profile that we're talking about, more confusion, inability to sense that the bladder is properly needing to be voided. So diuretics, obviously this kind of makes sense, right? If you have to urinate all the time because of large amounts of diuretics that are happening, you want to probably kind of pare those back. Now, some people need them, but timing is something that we can maybe talk about, and maybe decreasing the dose. So that can cause urgency in and of its urinary incontinence in and of itself. Blood pressure medications. There are some blood pressure medications like ACE inhibitors that can cause chronic cough. When chronic cough happens, one of the side effects you can have is the effect on your pelvic floor. Cough and particularly chronic cough can lead to weakening of those muscles, which can then lead to both urge and stress incontinence. And let's see, I think I had a couple more. Gabapentin, and that's a medication many people are on for pain, neuropathic pain, diabetic neuropathy, other types of neuropathy. It can cause swelling, and as a result, nocturnal symptoms of incontinence. So paring down the medication list is kind of one of the first things that we can look at, and high effective things we can look at to reduce symptom burden, because as I will keep hammering in this talk, it is a symptom-based disease. Quite often, it is not something that is life-threatening, but it is life-altering. So, all right. So, like I said, this is a complex topic because it often manages to seep into many different parts of our lives. The most important thing is that got to optimize the underlying medical condition. So one of the first things I have up there is sleep apnea. Somebody having worsening symptoms at night, more than 2 episodes at night of large volumes of urine, that can be a sign of sleep apnea, especially if you're waking up tired, you're snoring quite a lot. maybe you have undiagnosed sleep apnea. It can lead to worsening signs of incontinence. So you could almost look at incontinence as a way to say, hey, my body's not quite working as well as I wanted it to. It's the danger sensor, you know, in some ways for some of these conditions. On here, obesity, weight loss significantly helps with putting that pressure on your pelvic floor, as I was talking about earlier. A large percentage of people, up to 60%, can see cessation of their symptoms with weight loss. And it makes sense, right? If you have more weight in your gut, you have more to kind of, I guess, support when we're talking about your pelvic floor. So if you already have a weak pelvic floor, any kind of extensive and extra weight on top of that would lead to worsening of any kind of incontinence. Type 2 diabetes, so especially if it's uncontrolled, and that's the important part. Any kind of sugar that is coming into your urine can cause you to need to urinate more. And that's what we call polyuria, when you're urinating out quite large volumes of urine. So any uncontrolled amount of sugar in your blood gets sensed by your kidneys. And your kidneys are pretty smart. Your kidneys say, all right, we need to relieve that. We need to urinate out the sugar. So consequently, you urinate out your sugar, and the water follows the sugar, so you urinate out large amounts. So controlling diabetes is another way we can kind of fix some incontinence. All right, heart failure. A sentinel symptom of heart failure, actually, and one that we kind of look for when you may be undiagnosed or looking worse. How do you urinate throughout the course of the day? If somebody's telling me that, yeah, throughout the day I void a little bit, and then I fall asleep or I lie down, and every time I lie down, I suddenly have the need to urinate large amounts. That could be a sign of not working heart, especially because you aren't getting enough blood to your kidneys. The effect of lying down has been hypothesized that basically you are not getting enough blood to your kidneys, and then when you remove the gravity issue, you get enough blood flow to your kidneys, and suddenly you start producing urine. So again, another symptom-based elicitation can kind of help us optimize your underlying health conditions. And like I mentioned earlier, a chronic cough. You're constantly having a chronic cough, often due to smoking, which I seem to have not put up here, maybe it's the next slide, but chronic cough. A cough often elicits stress, incontinence, and loss of urine. Chronic cough can precipitate that, actually, just due to the constant burden that is being placed on your pelvic girdle. So, all right. Now, we always stress lifestyle interventions when it comes to pretty much any disease that we can target with lifestyle interventions. So, avoiding the hydration extremes. Obviously, more than 64 ounces, you're probably just gonna need to eject that out of your body no matter what, you know? But underhydrating has its own problems, and I think, if any of you have seen Dr. Wright in the clinic, you know that he likes to hammer the importance of dehydration. So it's really avoiding the hydration extremes. Something I did not put up there is avoiding, maybe kind of tapering your water intake as you start heading towards your bedtime, maybe limiting within the 3 hours or so before bedtime, so then you don't have as many nocturnal symptoms. Caffeine limitation. I tried finding recommendations for exactly how much caffeine, and every study pretty much said, don't consume extreme amounts of caffeine, whatever that means. So what does that mean? I'm gonna take it to interpret about 3 to 4 cups of coffee a day, and then over that we start running into trouble. On there, I missed it. Alcohol. Alcohol often causes some issues, especially with the need to urinate, kind of a decreased ability to move, immobility, especially if you had too much. And it will cause you to it acts as a mild kind of diuretic. You will have to avoid more if you are having significant alcohol, especially in the night. I did put smoking cessation up there. Well, I already covered it. So weight loss, less pressure on the pelvic floor, as I kind of mentioned. Like I said, 60% of people have some cessation of their symptoms. But this is not just in the geriatric population. This is kind of in younger populations as well. Constipation. Obviously, if you're having to struggle to struggle to pass stool at every opportunity, you're confusing your pelvic floor muscles, and you're likely weakening the set that is isolated around kind of your urethral sphincter. So preventing constipation is also important. Um, that way we eliminate another variable that is putting stress on your pelvic floor. All right, so I've talked a lot about, hold on a second. Is it busted? There we go. Okay, so conservative therapies are what we kind of move to next after optimization of your underlying health problems and kind of some of the things that I talked about earlier. So conservative therapy, pelvic floor therapy, this is kind of a diagram right here of your pelvic floor that I've been talking about pretty much the entire talk. That can especially help with urge incontinence. These are kind of Kegel exercises, and the way that they have been described, especially in usage for managing urge incontinence, is the following. It's being able to isolate the muscles that are kind of not related to the anal sphincter, but just to the urethral sphincter. Doing a slow contraction of those muscles for about 6 to 8 seconds in about eight repetitions, 3 sets of doing that. And the idea is to do that 3 times a week, and do that for about 2 months, and then see how things work in terms of a pelvic floor therapy strengthening. So some of that is hard to do because it's difficult to isolate that feeling. So there are physical therapists who are trained in pelvic floor therapy, and a lot of that training comes from post birth and kind of helping women to avoid stress incontinence down the road. But it's useful in this context as well. Bladder training. Bladder training is defined as trying to schedule void yourself and slowly move out that interval until you're at about an interval of 4 hours. So the idea being urinate, try and keep the volume low in your bladder, and then urinate 2 hours later, urinate 2 hours later, and keep repeating that. And then after a couple of days of not having symptoms, move that interval out to 2.5. Do the same, repeat 3 hours. Keep going, 3.5 to 4 hours. So some of that is just kind of neural remodeling of how your bladder can function, and it's helpful initially, at least. So, and I brought this up here, which is another way of kind of rescheduling how your brain looks. This is the urge suppression kind of model. So it's basically you feel the urge to urinate, just stand. So the idea is stand still, kind of squeeze those pelvic floor muscles that we were talking about earlier, the Kegel muscles, about 4 or 5 times. Kind of hope to take a deep breath, see if that urge is extinguished, and then distract yourself, kind of see how things work for the first 20 seconds or so, and if still having that urge, then walk up and go to the bathroom. One thing I haven't really covered in this talk is also kind of mentally restructuring how places you are frequently should be. Like, make sure you have easy access to the bathroom. Urge incontinence while you're rushing to go to the bathroom and then fall would be a pretty disastrous complication of something that should be life-altering, but which is, life-affecting but not life-altering. So this is just but one way to kind of schedule how you're feeling around urge symptoms. All right, medication. I like to call this second-hand kind of. The first medication up there, Flomax, we kind of prescribe it for overflow incontinence. The idea is to relax the urethral sphincter, and instead of having a constantly distended bladder like an overflow continence, your ability to fully relax that sphincter and provide proper voiding is the goal. Let's see, oxybutynin. So I talked about a dirty class of medications earlier called anticholinergics. Unfortunately, this belongs to that. The idea is it's used in urge incontinence to stop the spasming of the bladder, the premature kind of contractions, the feeling and urge to go. However, often this leads to unintended side effects. I talked about I talked a little bit about confusion and the like that happens, delirium. This also causes the shorter formulations, the short-acting ones, dry mouth, can cause constipation, dry eyes, dry skin. So it can help relieve symptoms, but we tend to be pretty vigilant about the side effects here. A newcomer, relatively, is mirabegron or myrbetriq. Good medication. It doesn't have the same kind of side effects as I was just listing about the anticholinergic medications. In particular, the thing to watch out for more is hypertension. It can aggravate hypertension because those medications called beta blockers, this is kind of the opposite of that, is a beta agonist. So it acts on different receptors in the brain. So it can cause, if you have really bad hypertension, it can exacerbate that. There's another medication that is not on here. It's called solanepicin or Vesicare. Not kind of a similar kind of issue. It can cause, it has kind of intolerable side effects. I like to say a lot of people get gastritis because your stomach kind of slows down and you get distension with that. And if you have any liver disease, it's not worth using either. So there are side effects that often can lead you to peril as well. So I think that's what I kind of talk about. So now we're getting into third line therapies, and Dr. Skagg is going to talk about that. Some of these I think they have a lot of potential for helping out, but we don't have as much experience with them, and often we're not the ones managing it. So, there you go.
Thank you. Okay, yeah, like he said, so these are third line therapies. So this is after you've failed conservative management, the exercises, the medication. Then if at that point you aren't already seeing a urologist, then you probably should be, and that's where you would go to have some of these therapies done. So I organized these from like least invasive to more invasive. So one of the more studied therapies is the tibial nerve stimulation. So it is what it sounds like. You go into an office, usually outpatient setting. They place a needle with a little electrode into your heel, actually around your ankle, medial ankle. And then that sends a stimulation up, all the way up to your sacral nerve. So here's your tibial nerve, all the way up into the sacral region, which is where a lot of this motor sensory function is at on the bladder. And really this has been studied more in overactive bladder, which is a type of urge incontinence where you have overactive detrusor muscle activity of the bladder. So this is really where this has been studied the most. Usually therapy lasts for about 12 weeks. You go into the office once or twice a week for 30 minutes and have the stimulation done. It shows about 30 to 40% improvement in symptoms over 12 weeks. Most patients say that their symptoms have improved that much. So it's a relatively good therapy, not very invasive, not super time consuming. The next one are the botulinum injections. So you probably heard about Botox injections for wrinkles and other things. So this is kind of similar to that, a little more invasive. So this is also outpatient, but it's in your urologist office. You go in, they use the scope, go up into the bladder, and they do Botox injections into the bladder wall. Here you can see it. And that's just to help, in a way, paralyze the overactive muscle that's sending the sensation of needing to go into your spinal cord and up into your brain, and then causing the incontinence. So this has some good studies with it, not super well studied. It's similar in efficacy with the tibial nerve stimulation. So people say, overall symptoms seem to improve. You can get multiple injections over a few months, only so many within a year, but then you can always go back and get maintenance injections if you need that. But pretty good overall. A little more invasive, and one of the risks that you run is a UTI. So this is kind of invasive, a scope's going up in there. So if you're already frequently getting UTIs, this probably is not the best option for you. And then this more invasive, but I think kind of cool therapy, sacral neuromodulation. So in this, you go in and there's a trial period. So they place an electrode here in the S3 area, like around your spinal cord, not necessarily in it, but there's like a little foramen, so it goes through the S3 foramen, little electrode, and it sends signals down. And you have a trial period, so at first they just leave the electrode on the outside of your body. You document your symptoms over a week or so, see if it's improved your symptoms, and if you have a 50% improvement of your symptoms, then they'll have you come back into the office, and they place this just above your buttock. It's similar to a pacemaker. If you have a pacemaker, I've seen one of those, just right inside your skin, except on your buttock, and then that sends this electrical stimulation down through the sacral nerve. And so I tried to outline it here, kind of how it's working. So it's sending this signal here, like in the sacral region, and that's going out to the S3. And one of the ways that they think that this works is that it's interrupting the signal, the sensory signal of the stretch receptor that's telling your brain that you need to go when you don't necessarily need to. Either through inhibition or excitatory mechanisms. There's a lot of different articles about it, and people are still kind of speculating on how exactly it's working. But really, they think either through inhibition or excitation, they're interrupting this signal, which can lead to improvement in symptoms. These can last up to 15 years before you need a battery replacement. One of the only big issues people have with them usually is that it may not work correctly. If you don't get the electrode like in the perfect position in the foramen, then you may not have the improvement of symptoms like you should. And they can always go back and, try to replace it. So these are just some other therapies that we have. And then, outside of these, if all of these were to fail, then there's surgical options, which really I didn't get into, but, sometimes they will do like a suprapubic type catheter and other things if you're having a lot of symptoms, but really we would try to stay away from the other surgical options. So that is it. Okay, that is not it.
I think I put this in the wrong place because I was trying to talk about optimizing underlying conditions. One of the things that didn't talk about were just genitourinary syndrome and menopause. Quite often can lead to, symptoms of a urinary tract infection, burning, irritation, and then due to basically tissue thinning as a result of a loss of estrogen can lead to some incontinence as well. It's not uncommon, and actually topical estrogen generally found to be pretty effective. Oral estrogen actually can worsen some symptoms, so we don't recommend it. But that was more in the catch-all kind of section of doesn't really fit into the other kind of symptoms, but it does occur. That, and I think I may have had a section on pelvic prolapse. Nope, but in terms of interventional therapies, women who've had pelvic organ prolapse often get managed with pessaries, but some of these therapies can be co-added to such. So yeah, all right, that's kind of our talk. So hopefully, if you guys have any questions and the like, we're here to field them and kind of go off. So
Yeah. Hope there will be questions. Don't be inhibited. Easy to say, isn't it? I think you ought to start your question off by, I have a friend who has a problem. And I'm sorry. Yes.
If you have one of the last,
The nerve stimulator.
where you put in that thing in your buttocks, does that interfere with a pacemaker? So you've got all these things.
No, I'm told it does not. It doesn't.
No.
Okay.
Yeah, it's okay to have both. Yeah. yeah, there shouldn't be any interference. And they actually have MRI safe electrodes too, just like they do with pacemakers. So
And I think in terms of both those procedures, tell me if I'm wrong, I think you can have a trial run of both of them before you have the, yeah, yeah. So you get to test to see whether it works before you commit to, and even after you get a permanent one placed, it can always be taken out if later on you change your mind for some reason. Well, there's Helen. You weren't here when I was introducing Dr. Skaggs as being a graduate of the University of the Ozarks. I knew you'd be happy about that. Any other questions? Yes.
I'll make it kind of personal in the fact that I have stage 3 kidney failure, which is not really serious, but it's a problem. And I wonder what that will contribute to the problem of urinary incontinence, or even the business of nocturnal polyuria.
Shouldn't. Often the problem we have with chronic kidney disease is you do have some polyuria that is occurring, especially as your nephrons in your kidney kind of fail to start filtering out as much. But I think it depends on what the kidney disease is being caused by. Like I said, diabetes, that would be a reason. Protein loss in the urine, that could be a reason. So. And if there's any, often the heart and kidney are kind of related. So, like I said, if you're not having one or the other, they're often linked. So, but it's not what I often think about, unless it's due to unable.
In most cases, it'll
Yes.
be unrelated.
Yeah. So
One won't aggravate the other. Yes. Sure.
You've really kind of touched on it, but I want a clear explanation, if you will, of why it is that if you're normal, you can urinate in the daytime at the appropriate spaces of time. At night, you can go completely through the night with only one, maybe two needs to get up. Why is that? How do you explain that?
Why do you go less frequently during the course of the night versus the day? Mm-hmm. Got an answer?
typically you just tend to concentrate your urine a little better. So your concurrent, not to get too much into it, but your kidney basically concentrates your urine a lot more. So you're not having as much distension of your bladder just through lack of urinary production. So that's why you don't have to get up and go as much. So
I'm not sure.
it's a desmopressin related. It's an ADH concentrating thing. So in your posterior pituitary, it releases a hormone called ADH or vasopressin, or antidiuretic hormone is what ADH stands for. So when that ends up being secreted, you basically have more water absorption in the last part of your kidney, and so increased water absorption kind of leads to preserved blood pressure throughout the night and a lack of secreted urine, which ends up in your bladder. So that's one of the proposed mechanisms. So. Yes, possibly. Actually, we don't prescribe it very much, but one of the therapies for nocturnal polyuria is providing a synthetic form of that hormone. So, but it has a lot of side effects, including most significantly lowering your sodium, which can be life-threatening. So we have gone away from it, prescribing it for that reason. So.
Yeah, I haven't seen that used in quite a long while. In some people, by a mechanism I haven't seen adequately explained, but some people just with age start having increased frequency at night. nocturia of aging, they call it. Fortunately, it's not the majority of people, but those who have it, it's kind of lousy. Yes.
I'm one of those 4 or 5 times every night. And it's very disruptive. I also have to sip water throughout the night because of my Sjogren's syndrome, and I'm dry. So I don't know. It's real puzzling to me. I can get up and go back to sleep for an hour and wake up and feel this tremendous pressure to go again, and I just went. So it's very frustrating, and I haven't figured out what I can do yet. So if you have any suggestions.
Answers? I think we're drawing a blank on all of this at nighttime. Yes.
Well, yeah, it sounds like you could have a component of urge incontinence. Like we talked about, there's several different things we can do for that. I really recommend going in and seeing your doctor so you can have a good discussion about it, and what would work best for you, because really it's individualized. It depends on what your problem is. You need to take more history and ask more questions.
I was just going to share that I was having a similar, of course, my body and my individual situation is entirely different. That's why you need to go to a urologist. But when I was going every 2 hours in the night, it was very disruptive to sleeping. And trospium is a drug that was very helpful for me. And so there are things. I mean, you mentioned some of them, but it's best to get somebody that knows what they're doing to decide on that.
Yeah, people who have diabetes, and if their blood sugar is running high, that causes a diuresis, an osmotic diuresis that is just going to aggravate incontinence. But even if you don't have incontinence, it's going to give you frequency, especially at night.
I can hold it, I think, yeah. I have a friend who spends a lot of time in a wheelchair, and people who spend a lot of time in wheelchairs have trouble physically urinating. It's difficult to go to a toilet. I use a urinal quite often, but I am wondering, since these people often have progressive diseases, that at what point do you decide that a catheter becomes necessary or extremely helpful? And what kind of aids are available?
You want to take a shot at it?
I'm loud, but I'm not that loud. So, the first thing, life is full of practicalities, and I think you bring up a very good point. That was one of the things I poorly articulated. That access to the restroom is kind of its own problem. Unless you're having significant urinary retention, a chronic Foley is probably never really indicated. It's very safe to do intermittent catheterizations. A lot of it is technique, and a lot of it is can be kind of just practiced. And that's what I think about when I think of catheters and urinary retention. So, typically that's where I think of Foley care, especially in the if incontinent. So
Where that line is so
Very hard,
individual, so much unique to the individual, that the answer is a little different in everyone. But because as you well know, there are trade-offs. And to say that's just not convenient is is clearly someone who has not had the problem, but whether it's worth the risk of the several kinds of complications you can have, starting with infections, but others as well. And yet there's some who do fine with it. So it's a hard, difficult answer to that question.
Yeah, and one of the ways that we look to see if you're not having adequate enough emptying is after you void, trying to see with a bladder scanner or a ultrasound how much urine is left. So if you start having increasing volumes, then we're talking about intermittent kind of catheterization. So especially in terms of neurological disease and progressive diseases. So
Other questions? I'm so proud of this group. See, they're not inhibited at all. I knew that they.
Well, I have a comment that can be turned into a question, I think, but I do have some trouble with this nocturnal polyuria. And what really, of course, it's unpleasant and it's not something that you really want, but what really worries me is the fact that it's disrupting good sleep. And all that you hear about nowadays is what happens to your brain and the rest of your body when you don't really sleep well. And the most recent thing I've run across in a medical report is that even if you have good quality of sleep while you're sleeping, if you have disrupted sleep, it can lead to atherosclerosis. And so I just wonder, how seriously you take this implication of the effect of disrupted sleep because of the polyuria.
atherosclerosis, yeah.
Atherosclerosis. So
Yeah.
the plaques in the arteries that cause.
That makes sense. When you wake up, you have a pulsatile release of cortisol. So
For
that,
most,
yeah, go ahead, Dr. Wright, sorry.
well, for most people who aren't getting up every hour anyway, maybe every 2 hours or more, it's the big question is how quickly do you get back to sleep? I mean, if that interruption every 2 hours is followed by 30 or 45 minutes of not able to get back to sleep, then it really does invariably disrupt sleep.
I think it's something that still has merits on what we need to investigate, because not all atherosclerosis is the same, right? You can have pretty hardened arteries that still have good flow through them, or you could have just one big occlusion, which could be more problematic and more acute. So as to which kind of atherosclerosis is caused by a lack of sleeping, I think it would be hard to tell. I think there have been I've read some studies on cerebrovascular atherosclerosis as well, and that's thought to be impaired by, there's some cells in your brain which kind of clean up the detritus in your brain, the microglial cells. The theory is that they don't work as well if you have interrupted sleep. But again, I don't really know what this means clinically. So.
The studies you read, do you remember what areas were involved? In general. Yeah. So really it could be in any part of the circulation. Interesting, fascinating stuff. Any other questions? You haven't had one question. You've had them all answered. Yeah, okay. Well, thank you all for coming. There's one last question. I'm not sure why I didn't have them do all the walking. We were just thinking that, yeah. Or why they didn't offer.
I just wanted to ask what you think about stress, because I'm one who cares so much for everything that's happening in our world, and especially in the schools, and especially in a private covenant Presbyterian. how much does stress affect your ability to, when I have a good night's sleep, I don't have any problems when things are settled a little bit. But when I don't, I do have problems with incontinence. So I just wanted to know.
Many different ways we could kind of take that. I think we talked about cortisol's kind of spiking in terms of emotional stress. Actually, if I were to extrapolate that, leads to higher blood pressure, leads to water retention, is what I would think about when I'm thinking of an excess cortisol state, which is stress in its own way. Lead to you urinating out more. So now, obviously, a lot more that could kind of be asked. Are you drinking a lot of caffeine to kind of stay up to date with things? You know, are you sleeping less in general? So hard to tell, but you know.
And I would just say, in a general way, to answer your question, it's hard to overestimate the effects of stress on the way our body works and the symptoms we have. So stress is notorious for causing all sorts of symptoms. Thank you so much for your attention and your attendance and your support. Good job, guys.